All right, so Chapter 8, Cervical and Thoracic Spine Osteology. This is the one that I didn't record the other day, so I'm going to go through it and then post it. So, vertebral column. We have 5 divisions, okay? So we have the cervical vertebrae with 7. We have thoracic vertebrae with 12. Lumbar vertebrae with 5. And then our sacrum is 5 when we're a child, 1 as an adult. It fuses together. Coccyx is 4, and then 1 as it fuses together for an adult. So a child can have 33, and an adult will have about 26. So keep that in mind for questions. So also the other thing to look at here is that we have our spinal cord that runs from our cervical down through our thoracic, and then about C or L1, we get the conus medullaris, and then we get just the offshoots coming off of the lumbar spine for our spinal cord. Okay, so normal spinal curvatures, we have the first compensatory curve, which is our cervical curvature. It's concave, and we can also say that it's lordotic, although usually we don't talk lordotic with a normal curve. We usually only use lordotic for exaggerated curvatures, okay? So first primary curve is the thoracic curvature, and it is convex. The second compensatory curve is the lumbar curve. It's also concave. We can also talk about it being lordotic as well, just like the cervical. We don't, because once again, just like up here, it's only if it's an exaggerated curve do we really use lordotic, but it's not wrong to say that it's a lordotic curve, okay, and concave. So the second primary curve is the sacral curvature, and it is convex, just like the thoracic curvature, okay? So first compensatory curve, second compensatory curve, first primary curve, second primary curve. So you know that first and second are concave, first primary, second primary are convex. This is when we use lordosis and kyphosis. So kyphosis is an exaggerated thoracic. So our thoracic here, it's exaggerated. It gives us a humpback look, and it's an increased convexity. Lordosis here for our spine is an exaggerated sway back in the lumbar, which is an increased concavity for our lumbar spine, and that's when we would say that we have lordosis. So exaggerated curvature is when we're going to use lordosis, and exaggerated thoracic curvature, we're going to use kyphosis, okay? So scoliosis, abnormal lateral curvature, we have the usual spine, okay? So it's straight. There is no abnormal curvature. You can have a normal curvature. So here's a little lateral curvature that they're calling normal. It's not scoliosis. It's just a normal lateral curvature. Now you have scoliosis, which is abnormal, and it becomes exaggerated lateral curvature before it finally comes back to straight. So this would be your normal spine. This is that exaggerated curvature as we come around, okay? So along with these exaggerated lateral curvatures, we can also have vertebral bodies that kind of start to twist. So you're not going to see equal transverse processes on either side. One of them is going to start to go more posterior. One's going to start to come more anterior, so you start to get a twist in your spine as well. So this is all part of what happens with scoliosis, and it's just something to keep in mind as you start to image scoliosis patients. So typical vertebrae, this is just discussing what a typical vertebrae looks like. You've got your body. You're going to have your pedicle here you're going to have your lamina here, and then you have your spinous process. So typical vertebrae, that's the way it's going to be. Your vertebral body, pedicle, lamina, spinous process. Typical vertebrae are going to have a vertebral foramen. So the vertebral foramen is for the vertebral canal, the spinal column. So we also call it the spinal canal. And our spinal cord transcends down through there and is protected by that vertebral canal. Okay, so the body is anterior, spinous process is posterior. So typical vertebral anatomy. Once again, like I said, there's the pedicle, there's the lamina, and then our spinous process here. We have the body right here. That's vertebral foramen for the spinal cord, the spinal canal that we sometimes say, and then our transverse processes. We also here on this lateral view for this vertebral body, we can see that we have superior articular processes and inferior articular processes. We're also going to talk here about this inferior vertebral notch and then this superior vertebral notch, okay? So the inferior vertebral notch, so this would be an inferior vertebral notch. This would be a superior vertebral notch. Those create that intervertebral foramen that we'll talk about as we go along here. So typical vertebrae articular processes, which we already talked about. We have the superior articular processes, 2 of them, and then we have 2 inferior articular processes right here. They will have facets on them, therefore creating a joint space depending on what's going to attach to it. The superior articular process is going to attach to the inferior articular process of the vertebral body above it. The inferior articular process will attach to the superior articular process of the one below it. When they join together, the superior and inferior, they create what is called a zygapophyseal joint, okay? So this transverse process right here is going to have a facet on it for a rib, okay? So zygapophyseal joints that I kind of just explained, we have the superior and inferior vertebral notches. So here's the superior vertebral notch, here's the inferior vertebral notch. Those create the intervertebral foramina. Superior and inferior articular processes. So we have the superior articular process, we have the inferior articular process. Superior, inferior. Superior, inferior. When that superior and inferior come together, we create a zygapophyseal joint, okay? Zygapophyseal, zygapophyseal, zygapophyseal. So the superior and inferior articular processes form the zygapophyseal joint. This is review. Use these images to review your anatomy. Keep in mind that C1 has an anterior arch and a posterior arch. They do not have a body or a spinous process. So this is a spinous process. C1 is an anterior arch. This is a body. This is an anterior arch, okay? So posterior, anterior arch for C1. Intervertebral disc. This intervertebral disc is a shock absorber between the vertebral discs. You have a vertebral body above and a vertebral body below with the intervertebral disc in the middle, creating a shock absorber so it's not bone on bone. With this little shock absorber for this intervertebral disc, it is made up of annulus fibrosus, so just fibrous tissue around this gelatinous nucleus pulposus inside, okay? So when you have this annulus fibrosus, which is the outer portion, and the nucleus pulposus, that soft, semi-gelatinous inner part, and you have anything that goes wrong, you have compression compression so much that it causes the nucleus pulposus to protrude through that annulus fibrosis, you get what's called a herniated nucleus pulposus, an HNP. So the nucleus pulposus protrudes through that annulus fibrosis, and when it does that, if it's headed towards the spinal cord, it will impinge on the spinal cord and can cause issues as it presses on there, okay? So we're going to jump to our cervical spine. We have 7 vertebrae in our cervical spine. We have typical cervical vertebrae. And as we talk typical cervical vertebrae, we are talking about C3, 4, 5, and 6. Those are typical, okay? 7 is not typical because it has this long vertebral prominence, this spinous process. We use that as a place to palpate for our chest x-rays. So it is a vertebral prominence that is not typical of C3 through 6. So C2 is another one that's not typical. It is not typical because it has a dens, okay? So that dens protrudes up and attaches to C1 via tendons to allow the head to turn. C1 is not typical because we've already talked about it. It has a anterior arch and a posterior arch, where the other ones have either spinous processes and bodies, okay? So C1 has anterior arch and posterior arch. So typical cervical vertebrae, C3 through 6. And then we're going to talk about 3 unique characteristics, okay? So the first one is bifid spinous processes. So the bifid tips, bifid spinous processes. You can see that spinous process, the bifid tip on 2, 3, 4, 5, and 6. So when we're talking the typical C3 through 6, they are going to have bifid tips, okay? So bifid tips. Also, articular pillars. This is an articular pillar. It is not a process, basically. It has a superior articular facet. So it's an articular process, but we call them pillars instead of individual superior articular process, inferior articular process, as you would see with these vertebrae right here, as far as a superior articular process, inferior articular process. This is not a pillar, okay? So it's only in the cervical spine that we have pillars, okay? And then the last one is 3 foramina. So the 3 foramina that we're talking about in the C-spine is we have 2 transverse foramen, transverse foramen, and then the typical vertebral foramen that all of our discs or our vertebrae have. So cervical is different because they have the 3. They have the transverse foramen. That transverse foramen is used for veins and arteries to run up through the neck to support them and allow blood flow to the brain. So intervertebral foramen, this is showing us right here our central ray and our central ray. So this is a central ray for a lateral. This is a central ray for an oblique. This is talking about the C-spine. So in the C-spine, a lateral image of the C-spine, you're going to image the zygapophyseal joints. In a 45 oblique for the C-spine, you are going to image the intervertebral foramen. We also have to keep in mind that when we're doing an oblique C-spine, it's intervertebral foramen at a 45 oblique with a 15-degree cephalad angle. We need that angle to open up those intervertebral foramen, okay? If we go 0 degrees, we're going to close off the intervertebral foramen. We need that 15-degree cephalad angle to open up those intervertebral foramen. So our atlas, we talked about our atlas. It has the posterior arch, the anterior arch. It has the articular pillars. The superior articular process here actually attaches to the skull, and it creates the atlanto-occipital articulation. Okay, so remember C1 is going to have an atlanto-occipital articulation with the skull, and then the articulation that it's going to have with C2 is going to be, we call that, it is either a zygapophyseal joint, or we can also call it the axial atlantal joint, or the axis atlantal joint, either one of those. So you're just using the axis and the atlas axis joint, atlas axis, whichever one, or just a zygapophyseal joint, okay, on the pillar. So this is the atlanto-occipital, and then this is a zygapophyseal joint, or the axial atlantal joint. Okay, so C2, it does have a body, and the dens protrudes off of it. So it has the superior and then the inferior articular process. But once again, it is called a pillar that those articular surfaces are on. Okay, and then we also have the transverse foramen, and then also the vertebral foramen in each one that spinal cord protrudes down through. Our open mouth projection, review A through G. We went over this, but make sure that you review it so you know what they're called and you can label them and identify them. Now we're into the thoracic. So thoracic characteristics, we have distinctive features, which are rib articulations. So as the ribs articulate with the vertebral body, they are either called facets or demifacets, okay? So on the vertebral body, you have vertebral body 1 that has a facet for rib 1. And then it has demifacets for rib 2. So the demifacets are split. So rib 2 attaches to 2 and 1. So instead of calling it a facet, it's a demifacet. So as long as, say, an individual rib attaches to an individual vertebral body, then it's going to be called a facet. If it comes in and it makes the attachment on the one above and one below, then those are called demifacets because they're split. Okay? So also in the thoracic spine, your spinous processes start to project caudally. Okay? So that's a characteristic of the thoracic spine, is that the spinous processes point caudally. Okay? This is just once again talking about the rib articulations for facets. So facets for rib 10, 11, and 12, since they just attach to one, they're not split, so they're not a demifacet, they're just a facet. Okay? We already went over this. This is review, costovertebral and costotransverse joints. So when the head of the rib attaches to the vertebral body, that's a costovertebral joint. When the cervical of the rib attaches to the transverse process of the vertebral body, then that is a costotransverse joint because it's on that transverse process. Okay? So transverse process and cervical is a costotransverse joint. When the rib attaches to the vertebral body, costovertebral. Okay, So that should be really good review. Typical thoracic vertebrae is just like all of the other vertebrae. We have the body, we have the pedicle, we have the lamina, we have the spinous process, we have a superior articular process, inferior articular process. We also have the inferior vertebral notch, superior vertebral notch. As those join together and stack on one another, we have the intervertebral foramen. Typical thoracic vertebrae, this is a lateral view. Once again, we have body, pedicle, lamina, spinous process. We have that inferior vertebral notch, superior vertebral notch, creating the intervertebral foramen. As the spinous processes come together, the superior spinal process, inferior articular process, superior articular process, you create a zygapophyseal joint. Zygapophyseal joint. So superior articular process, the inferior articular process comes down there, zygapophyseal joint. Okay? So in our T-spine, once again, just like our C-spine, we're seeing some angles here. So we're seeing our lateral central ray, and then we're seeing an oblique central ray. In our lateral central ray, we are viewing our intervertebral foramen, where in our lateral for our C-spine, we were actually viewing zygapophyseal joints. So that's separate, that's different from the cervical spine. And then for our oblique T-spine, we are seeing zygapophyseal joints. When we were imaging our cervical spine, we had an oblique and we were actually viewing our intervertebral foramen. So separate those as far as the laterals, what you're seeing, and the obliques, what are you seeing. This 75 and this 15 to 20 or even 20 to 25, I will talk about this later. I think it's going to be on the last slide, and I'll explain to you what these degrees of rotation are meaning, okay? So AP axial projection, make sure that you review this so you know what it's going to be on your critique exam. It's in your critique review, and it's also in your book. The only thing that I can say about this image is we need this jaw and the base of this skull to be aligned. It is not aligned right now, so the base of this jaw or this jawline is obscuring C2. So if we superimpose the jaw over the base of the skull, we're going to see more of our C-spine, and we're going to have a better image. So anatomy review, lateral, keep in mind on the lateral, and for all of your C-spine, C1 has an anterior arch and a posterior arch. This is an MRI of the cervical spine, and it is highlighting a herniated nucleus pulposus. So the nucleus pulposus is protruded through the annulus fibrosus, and it is impinging on this spinal cord, and it is going to start to cause this patient some issues, if not already. So oblique cervical spine. Oblique, we are seeing these intervertebral foramen. Okay. We have C1. C1 has a posterior arch and an anterior arch. No body, and no spinous process. Just the arches, anterior and posterior. Our intervertebral foramen are made up of our inferior vertebral notch and our superior vertebral notch. The inferior vertebral notch on top, the superior vertebral notch on the bottom to create that intervertebral foramen. Anatomy review. Review this. Make sure that you can label all of this and more for a image critique review. Lateral T-spine. Notice on this lateral T-spine, be sure that you can label all of this. And notice also on this lateral T-spine that we are starting to see the intervertebral foramen. Okay? So this is a lateral, where if we go back here, this is an oblique cervical that we're seeing the intervertebral foramen. Now we're a lateral T-spine and we're seeing the intervertebral foramen. Intervertebral foramen, once again, are made up of the inferior vertebral notch and the superior vertebral notch. Inferior vertebral notch, superior vertebral notch will create that intervertebral foramen. Zygapophyseal joints. Zygapophyseal joints are seen on the lateral C-spine. You will see those zygapophyseal joints. An oblique, LPO, RPO, you will see on a C-spine intervertebral foramen made up of the inferior vertebral notch, superior vertebral notch. Inferior vertebral notch, superior vertebral notch. That's going to make that intervertebral foramen. Zygapophyseal joints. This is zygapophyseal joints on a T-spine in an oblique position. Oblique position is where you're going to see those zygapophyseal joints on a T-spine. So 70 to 75 and 20 to 25, what we're going to talk about here is what do these mean. So if I am imaging and I start off with my AP, which most people do for my T-spine. I do AP, and now I'm going to do my oblique, okay? When I go from AP to oblique, I'm going to turn my patient 70 to 75 degrees, okay, to get those zygapophyseal joints. Then I'm going to go ahead and place my patient lateral, and then I'm going to do a swimmers, okay? So if I'm talking the 20 to 25, I'm doing an AP, I'm going to do a lateral, then I could do a swimmers if I wanted to, and then I'm going to do my oblique, okay? So the lateral and the swimmers also imaged lateral. So from lateral to oblique, that's when I'm going to turn my patient 20 to 25 degrees, okay? And then if I go AP, lateral, oblique, then I could do a swimmers. So I can do my swimmers at any time. Lateral swimmers, then oblique, 20 to 25. Or I can do AP, lateral, oblique, 20 to 25, and then do a swimmers. So that's the difference between the 20 and 25 and 70 and 75, is if you're going AP to oblique, 70 to 75. AP, lateral, lateral to oblique, 20 to 25. Okay? So I will post this. This takes care of what we missed on Monday. This will get you all caught up, and I will see you guys next time. Have a good one.